This conference will now be recorded.
Welcome in, everybody. On today's lecture, we're going to be talking about Chapter 3, which is going to be medical, legal, and ethical issues. So first off, we have legal duties. We have a scope of practice that we must abide by. The scope of practice is determined by whatever state you're actually working in under that licensure. So me, as a paramedic, I work in the state of Minnesota. I need to abide by the scope of practice set forth by the state of Minnesota. When you guys finish this class and start working, you'll be working under the EMT scope of practice. So big issues with this is that you cannot exceed your scope of practice when you're rendering care. So an example, let's say that you are working on an advanced life support ambulance as an EMT, and your partner asks you to start an IV or do an advanced skill that's outside of your scope of practice. You could also, excuse me, get in trouble as far as breaking that specific scope of practice. The next, we have a standard of care that we must abide by. So this is in relation to our patient care and in correlation to another EMT with a very similar patient, very similar circumstance. What would they do in that specific situation? And then we have a duty to act. So duty to act is kind of goofy too, because a lot of organizations and providers are actually what's constituted as volunteers. But this is your legal obligation to provide that service. So if you are being paid on a full-time service or even a volunteer service where you have a duty crew or scheduled hours, when the tones go off, 911 system is activated, that duty to act starts immediately from those tones. Now, if you're a volunteer, that's a little bit different because you carry around a pager and are not necessarily on call 24 hours a day, but you do still have that duty to act in most circumstances. So when we're discussing these legal issues, ethical issues, moral issues, we also need to understand that we do have protection that governs us. So first, we have the Good Samaritan Law. So the Good Samaritan Law will cover us in the event that we are not being compensated as EMS providers. So for example, you're off duty, you're away from work, you're driving down the road and a car accident happens right in front of you. You get out, you render care to that individual, maybe you stop the bleed, what have you. You're protected under the Good Samaritan Law because at that specific time, you are not being compensated as an EMT. Now, when you are on duty, you must abide by all the rules and regulations that are governed by your organization, follow the legal duties that we discussed on the previous slide, and your organization is going to carry what's called professional liability insurance. So in the event that there's a wrongdoing or somebody brings a criminal suit against the organization and or you are covered under this insurance. And then we also have sovereign immunity as well. And this is in relation to a specific government agency that you're correlated with. If somebody sues your organization and you're a government agency, they can't go after the federal government or state government for allocated resources at all. So when we're looking at ethical responsibilities, keep in mind what we discussed within Chapter 1 as far as good moral traits of the EMT. We have a lot of trust and ethics that are correlated to our position. So make sure that you're making all of the correct choices. You know, the best example that I can give as far as giving your ethical responsibilities is treat every patient that you have like it's your mom. And if you do that, then you're going to abide by all the ethical responsibilities that is set forth for you as far as being an EMS provider. So just because the 911 system is activated does not mean that we have the right to start touching and or treating our patients. We always need some form of consent. So we have a couple of different types of consent. We have informed consent, in which all of our patients who are alert and oriented and conscious should have information relayed to them from us as EMS providers as far as what we're going to be doing, treatments, protocols, guidelines, and discussing with them that specific treatment plan. Now, as far as providing that legal obligation and that binding relationship between you and the patient, we need consent from that individual before we start treating them. If somebody's alert and oriented, they don't have any mind-altering substances in their system, they're considered an adult, which is 18 years of age or above in the state of Minnesota, then they're going to have to verbally say, yes, you can go ahead and treat me. This is going to be classified as express consent, where the patient is actually expressing themselves, yes, they want help at this point. The next one is implied consent, because not every patient is going to be alert and oriented or not under the influence of drugs or alcohol or have a head injury. Whatever the case may be, if you have a patient that is not in right mind and cannot actually provide that consent, this is what's going to be classified as implied consent, where if this individual was actually alert and oriented and in good judgment, that they would go ahead and comply with your request as far as getting consent. Next, we have minor consent. So individuals under the age of 18 in the state of Minnesota need to have a parent or a legal guardian as far as consenting in order to get medical treatment or refusal of that medical treatment. In the event that you have a minor, so again, 18 years of age or younger, and we do not have a parent or a legal guardian around, we're going to go ahead and treat that patient, and this is going to be classified as minor consent, with a caveat signifying that if there was an adult present or a legal guardian present, they would say, yes, treat my child or treat my guardian. Now, there are a couple of different goofy ones with minor consent. Emancipated minor, so if the government sees an individual under the age of 18 as an adult, they can refuse treatment for themselves. Also, mothers and or individuals who are pregnant, oftentimes they're going to be classified as adults, and they can make the medical consent decisions for themselves. Every state is a little bit different when we're looking at legal aspects. So make sure that whatever state you work in, that you really dive into some of those specific legal issues that we might see. And then we have involuntary consent. So this is going to be somebody who's refusing medical treatment, but it's in their best interest that they actually be seen and treated. And so law enforcement is going to step up at this point and then put them under involuntary consent. So law enforcement and medical direction has to be involved in this. We cannot, as EMS providers, force anybody to go to the hospital. We need that protection as far as law enforcement and medical direction in order to make that determination. So as far as how you can find yourself in legal wrongdoing when it's non-intentional would be in the form of negligence. So in order to get in trouble, the government's got to find you negligent, and within a specific case, they have to prove the following: that you had a duty to act. So again, you are being compensated as an EMT provider, you're sitting at the station house, your tones are activated, you had that duty to act. You then breached that duty. So that duty to act also entails your scope of practice and then also your standard of care for that patient. There were damages, and then there was proximate cause. So the damages are proximate cause to your duty to act and your breach of duty. A little bit confusing, with this legal jumbo, basically. Sometimes it's hard to pinpoint all these different things and how they can correlate. But let's say I'm working as an EMT and I get dispatched to an individual having a seizure. I arrive on scene, I do my scene safety, I do not check a blood sugar, even though that's in my protocol and my guideline and my standard of care and my scope of practice for this. This individual actually has a very low blood sugar, and that was the result of the seizure. So I did not treat that low blood sugar throughout the duration, and as a result, this individual went into cardiac arrest. I have met all of those 4 components as far as negligence by not checking a blood sugar on a patient who needed a blood sugar checked, and as a result of that blood sugar, to treat that hypoglycemic event. And as a result, I could be found negligent for my behavior and my duty when I was responding to that specific call. So there's a lot of other terms that we're going to discuss as far as abandonment, intentional tort, breaking the scope of practice, DNRs and everything. But instead of reading the definition by definition with some of these, let's put it in a scenario-based format. So you're dispatched to a nursing home. You have an 87-year-old male patient who began choking on a piece of steak at dinner. Patient's unresponsive, they're not breathing, unknown if he has a pulse. Under protocols from the nursing home, they are unable to touch the patient at this time, and patient does have a valid DNR. So a DNR stands for a do not resuscitate order. In the state of Minnesota, in the state of Wisconsin, you have to have a paper format that's signed by a physician and signed by the patient in order for that DNR to be valid. And that DNR has to be present upon your arrival. So if I were to arrive on this scene, the nursing home presents me a DNR, I check the patient, no pulse, no breathing, I look at the DNR paperwork, and yes, it is valid, it is in date. I have a physician signature, I have the patient signature, and or a medical power of attorney. Okay, I am not going to begin resuscitative efforts at this point. Now, there is a gray area embedded in this scenario, and that is a reversible cause. So most individuals who have DNRs or DNIs, and DNI stands for do not intubate, there is a small section under that DNR that states if there is a reversible cause, you can treat that. So for this scenario, the reversible cause would be the fact that the patient was choking, and that is a reversible cause. So we could potentially try and treat that injury or that illness. But most of the time it's going to be correlated to a disease process, cancer, Alzheimer's, cardiovascular disease, renal disease, what have you. A lot of these individuals are going to have do not resuscitate orders. You're dispatched, 89-year-old male patient, not breathing. Upon scene arrival, patient is noted as not breathing and no pulse. Patient's wife states that she has a DNR somewhere in the house, but is unable to find it at this time and asks you to leave her husband in peace. You grant her request and ask for law enforcement. Upon arrival of PD, you clear the scene and return back in service. So very similar circumstance to our first scenario. However, in this one, we do not have a DNR that is actually presented. So at this point, we could actually be found negligent because we had a duty to act and we breached that duty. And as a result, there were damages and proximate cause because of that. So again, the DNR has to be present with that patient in order for it to be valid. So this is a good educational tool for some of your family members who are getting up there in age and do have DNRs. Make sure that they are with them and or on the fridge, readily accessible in the event that something happens. So in this scenario, what we should have done as far as being good EMTs is the DNR is not with that patient, so we're going to consider it voided, and we're going to go ahead and start resuscitative efforts. You're dispatched, Holiday gas station, for a 16-year-old female patient who had taken a bunch of pills. 911 call was made by her boyfriend. Upon scene arrival, patient denies taking any pills at all. Boyfriend on scene stated that he did not actually witness her take some, but thought she did. Patient is prescribed Ativan for panic attacks, but her pill bottle is missing. Parents cannot be reached at this time. So now we're looking at a scenario where this patient wants to refuse medical care for themselves. And as we discussed earlier, an individual who is under the age of 18 cannot refuse medical care for themselves. So at this point, if the parents cannot be reached as far as getting consent, we're going to go ahead and treat and transport this individual. Now, in the event that she was 18 years old or above and does have the legal right to refuse, we have to go through some check boxes to make sure that she is in good judgment before she actually refuses care. So we always want to check mentality, and mental status. So where are you? What's the date? Who's the president? Ask them very basic information that they should be able to recite off to you immediately. And then way we're checking our mental status. So make sure that they're alert and oriented, check their vital signs, make sure that they're within normal limits. And then also anytime that somebody refuses medical care, we have to inform them of the consequences in the event that they don't receive medical care. So for this specific individual, if she did take Ativan and a bunch of it, we have to inform her that if you did take all that medication, it could potentially slow your respiratory status or completely diminish it to the point that you're not breathing and you could potentially die. With legal obligation, it's the best way to cover yourself by using the words dead, dying, or die when you are informing a patient who is refusing care. Whenever a patient refuses care, a heavy amount of documentation has to go through with your report, and that patient does have to sign that report saying, I am refusing care against medical advice. Your dispatch for a 56-year-old female patient with difficulty breathing. Upon scene arrival, you find the patient sitting in a chair with some shortness of breath. Patient is a frequent flyer. You had transferred to the hospital yesterday. You decide that the patient doesn't need to go to the hospital and tell her that. Patient still requests to be transported, but it's at the end of your shift and your give a damn is busted. You clear with the patient no need and return back in service. So what you did right here, again, is proven negligent and it's classified under abandonment. So if an individual calls 911 and you start to render care for that individual, you need to either continue to treat that individual until a higher level of care comes, transport that patient, and or receive refusal documentation. With this specific scenario, this individual was requesting medical care and we did not give it to her and we left that patient. Again, that's patient abandonment. Whenever we're handing off the patient, it's always got to be to a higher level of care or a care that can adequately treat that patient. So just because you are EMTs doesn't mean you can't transfer a patient to an EMR as long as that patient does not need any interventions or treatments within the scope of practice set forth by an EMT that an EMR cannot do. Within the state of Minnesota, the state of Wisconsin, if an individual calls 911 and wants to be transported to the hospital, it is our legal obligation to provide treatment and provide transport for that patient. Your dispatch for a cardiac arrest. You are 1 week away from getting your paramedic certification. Paramedics on scene are having difficulty intubating and ask you to intubate the patient. You successfully intubate the patient, receive ROSC, which is a return of spontaneous circulation, which means the patient starts perfusing again and that heartbeat starts going again on its own, and you transport that patient. So what you did, even though you were successful in your skills here, is you broke your scope of practice and you broke your guidelines, which you are working under. So first, as far as licensure level goes, you're an EMT in the state of Minnesota, so you have to abide by the scope of practice set forth by the state of Minnesota. Now we also have to work under our guidelines that are approved by our medical director with the specific agency that we're working. So for example of this, even though I am a paramedic, I am also a volunteer on Hermantown Fire Department. So if I arrive on scene and I intubate a patient, even though it's within my scope of practice, I'm breaking my local protocols and guidelines because I'm acting outside of those guidelines, even though I'm classified as a paramedic. So yes, we have to abide by our scope of practice, but we also have to abide by our specific guidelines and protocols for our agency that are approved by our medical director. If you go outside of that scope of practice or outside of those guidelines, that's where you can find yourself in trouble. Your dispatch for a female with abdominal pain. You approach Stevener and Maple Grove Road and proceed through a red light. An elderly female pulls out in front of you and you hit her driver's side flush going 55 miles an hour. Driver is dead upon assessment. So this could be classified as vehicular manslaughter. So yes, the state recognizes us as emergency medical responders, in which case we're awarded some leeway as far as responding to a scene, but it's relatively limited leeway. We can only go so fast. Whenever we come to a red light, we have to come to a complete stop, make eye contact with everybody, and then they have to yield us forward. We're not necessarily allowed to break any laws. So with that, what we need to do is drive with due regard. And due regard means that we're driving defensively and safely. Yes, we're going to get to that point, but make sure that we do so safely. There's a lot of research and data out there that shows that if we're driving 65 miles an hour in comparison to 50 miles an hour, how much time are we saving? And in most cases, we're not saving enough time in order to make that risk management decision. So keep in mind what your dispatch information is, what time of day it is, your weather considerations, how comfortable you feel operating that vehicle, and drive in a safe manner that you feel comfortable with. Your dispatch for a 6-year-old male patient who fell down a flight of stairs. Upon scene arrival, you find the patient sitting on the couch with his head in his hands. Patient is not answering questions, but just continues to say, "I'm sorry." Patient has multiple bruises on his body that are both new and old. Patient's father's on scene. He's very standoffish, not given a great deal of information besides the boy fell down the stairs and is very clumsy. As the EMS providers, what we are patient advocates, and we're also what's classified as mandatory reporters. So we have to report any type of abuse that's considered child abuse, domestic abuse, and or elderly abuse. Even if we don't know for sure whether it is, we still have to report that to law enforcement and make our suspicions known. So in this case, yes, we cannot prove that this is exactly child abuse, but there's a lot of criteria that's really jumping out at us as far as red flags. So child's got new and old bruises. When we're seeing that, some bruises are black and blue, which are going to be our new. And once they start healing, they turn a yellow or a green color. So with that information, and the kid is scared, continues to say, "I'm sorry," dad's presenting in that aggressive behavior, those are all information components that are leading us to believe that this might be a child abuse case, in which case we need to get law enforcement involved. Now, with patient assessment and treating that individual, it's going to be very difficult to actually treat and get the full story from that child when dad's around. So make sure that you request law enforcement right away and try and separate dad from the son or the patient so that we can actually get a proper history and start treating that individual. Yes, we do need consent technically from the father at this point because it is a minor as far as treating that, but this could also fall under law enforcement doing consent that eliminates the father from actually making that determination. You are dispatched to a 68-year-old male patient who cannot care for themselves. Call was made by a family member. Upon scene arrival, you find a patient in poor but livable conditions. Patient has cancer, has a DNR, is on hospice care. Patient does not have any complaints but is weak and has an increased level of breathing. You deem it necessary for the patient to go to the hospital, force him on the stretcher, and take him to the hospital. Again, everybody has the right to refuse until law enforcement or medical direction comes in. We cannot make that determination if a patient is alert and oriented. So what we did in this specific scenario is kidnapping, because we transported an individual against their wishes. And then also this could be considered battery and or assault because we touched them without their consent. So even in this scenario where it's pretty clear that maybe this individual should be going to the hospital, we need to get law enforcement involved and or honor that individual's wishes, in which case we have to go through the proper documentation of refusal of care for this individual. Your dispatch for a one vehicle motor accident with an airbag deployment. Upon scene arrival, you find a 16-year-old female patient with a head laceration, no other injuries. Her 9-month-old daughter is in the car seat in the back seat with no apparent injuries. 16-year-old female patient is complaining of head pain and may need a couple of stitches, but she is refusing medical care for herself and for her daughter. So we already discussed kind of this whole scenario. Yes, she's under the age of 18, so as a result, she should not have the right to refuse. However, she is a mom, she is under the care of that child, and as a result, most states will recognize that she is considered an adult and she can make that decision process and consent or refuse medical care for herself and for her daughter. Your dispatch for a female patient with a suspected drug overdose. You arrive on scene, treat the patient accordingly by assisting ventilations and administering Narcan. You know this female personally, and on social media mention her name and the medical emergency that she was involved in. What we did right here is we broke a very golden rule that governs us as EMS providers, and that's HIPAA. So HIPAA is going to be Health Information Protection Act. And so whatever we experience, all of our patients' records and history has to be protected. And this is one major reason why a lot of firefighters, EMS providers, and law enforcement officers are losing their job, because they're going on social media and they're discussing specific calls and specific people that they were on. Do not do this. If you have social media, that's fine. What I would recommend doing is not putting any of your work history. So don't say that you're a firefighter, paramedic, or an EMT, or an EMR, or a volunteer, what have you, on that social media aspect, because people tend to get themselves in trouble with social media. Protect your patient. You are patient advocates who do not divulge that information against their wishes. Your dispatch for an 88-year-old female patient, possible DOA. You arrive on scene, find signs of rigor mortis, modeling, and the patient is cool to the touch. You have a new partner with you and decide to work the cardiac arrest for practice for your new member. Mayo Clinic arrives on scene, assists in cardiac arrest efforts, contacts medical control, and terminates resuscitation efforts. So this is a very gray area in the legal aspect. We need to honor our patients, whether they're alive and or have been deceased. So when we make the determination whether we're going to attempt resuscitation efforts, we should do so in the mindset that we have a chance of resuscitating that patient, because there's going to be a lot of psychological aspects that go in with family members, and then also with billing concerns. So first, let's talk about family concerns, and then working a cardiac arrest event when we shouldn't, because there's obvious signs of death already noted and our chance of survival is 0%. So when we do CPR, when we do a bunch of life-saving interventions, we kind of mess up the body a little bit by doing chest compressions. We could cause bruising. We're going to insert a King airway or other airway interventions, and basically we're disturbing the peace at that point. So when family members, whether they're on scene or arrive on scene later, they find their family member with a bunch of tubes in them, that can be very disheartening and kind of shocking for that family member. It's much better to go ahead and leave them in peace, cover them up, so that family members, if they do arrive and or are on scene already, can say their goodbyes and see that family member as they remember, not with a bunch of tubes and AED pads attached to them. The second thing, which is ethical and moral issue, when we work a cardiac arrest scene or do any type of intervention like that, we do have the obligation to send that individual a bill for the service that we rendered. And so for individuals who are not transported, most health insurance companies will not actually pay the bill for that ambulance company because they didn't transport. So the family members might be stuck with $1,000 or a $1,500 bill that they have to pay out of pocket for this scenario in which you just wanted to practice. I'm not saying don't try to provide resuscitation efforts, but do so mindfully, and if there's obvious signs of death, leave the dead in peace. Your dispatch for a 54-year-old male patient experiencing chest pain. You respond on the scene and treat your patient. 2 months ago, your NREMT certification and your EMSRB license expired, and you failed to update both certification and license. So what we're doing here, even though you were an EMT at one point, you're now responding and treating a patient without a license. As a result, you're breaking the state scope of practice, and then also breaking your agency's protocols and guidelines. Because the reason why we can practice is under the tutelage and advice from that medical director. But the medical director will only allow us to practice if we have a valid EMS license. Every 2 years, we need to renew our license. And if we don't renew our license, that eliminates us from actually responding to and treating our patients. So make sure that you get your paperwork in time and renew your license within that 2-year time period. So that does it for our lecture on legal, medical, ethical considerations. A lot to dive into here. The biggest thing to do when we're responding is act with good conscience and always use common sense. If you use common sense and you follow your training and you follow the protocols and the guidelines, then you're going to be protected. It's when you try and do too much or you go outside of your scope of practice that you're going to find yourselves getting into trouble. All right, that concludes chapter 3. Thanks, everybody.